Alright, so this is the definition that I want you guys to sink into your memory on blood pressure. I understand that when you look at the blood pressure, there is a top and bottom number. But when I ask you what a systolic blood pressure is, or diastolic blood pressure, I don't want the top number or the bottom number. Alright? That's what a banker or a lawyer would say. You guys need to know the medical definition of these terms. So this is what I want here. When you look at blood pressure, it's the force exerted against the walls of the arteries by the blood. So the blood itself, inside the vessel, exerts an outward force on the arterial wall. That's blood pressure. Blood pressure is broken down into two different parts. The systolic pressure, or systole, you just change the N. Systole or systolic is the contraction phase of the heart, or the working phase. So anytime that you hear systolic, it's a working phase. Whether it deals with the heart or something else, it's the working phase. So the systolic blood pressure, which happens to be the top number, all right, is the pressure exerted against the wall of the artery during contraction or during the working phase. So that's the definition that I want you to have. Diastole or diastolic happens to be the bottom number, but it is the resting phase. So when you hear diastole, it means something's at rest. So diastolic pressure is the pressure exerted against the arterial wall during relaxation or rest. Those are exact definitions. Those are the ones that I want. The problem that people have with taking blood pressures is they don't memorize the step process or the terminology. So that's what we're going to work on. The systolic pressure is under much higher pressure, and then the diastolic pressure is under a lower pressure. This is an artery, which is under high pressure, and then a vein on the venous side, which is in lower pressure. There's this great video, this con video that I found the other day on blood pressure. We will, especially in cardiac physiology, we will watch a lot of con videos. If you're not familiar with Khan Academy, you will be soon. We use him a lot. One, he has this incredible way of explaining things that are very complicated and putting them quite easy. And it's very concise. A lot of his videos are only about 15 minutes, 10, 15 minutes. So it's a lot of good information at once. And he has one to explain the blood pressure that we'll watch right quick.
So recently I went into my doctor's office and I was told that my blood pressure was 115/75. So I thought we would talk about exactly what this means and try to figure out how to think about blood pressure in general, using these numbers and this experience as kind of a launching point. So the way I think about blood pressure is I always imagine kind of a tube, and I imagine blood going through that tube, and this tube is like a blood vessel. So there's blood trying to get its way from one side to the other, and on its way, the kind of neat thing that it's doing is as it flows, it's pushing out. So it's forcing against these walls. And specifically what I mean by that is, there's cells and there's plasma, and all that stuff is pushing out against the walls of the blood vessel. So you've got a force, and that force is being exerted on the surface area of the blood vessel. So it's force over a surface area. And anytime you see force over an area, you know that equals pressure. And in this case, it's a blood pressure because it's the blood that's doing that work. So this is how I think of blood pressure, specifically those little blue arrows. And the two questions that kind of pop into my mind anytime I'm thinking about blood pressure are, where is the blood pressure being taken, and when are you taking it? So let's start with the first question, where? And by that, I mean where in the circulatory system. So you've got the heart, and it's my Valentine's Day heart, and you've got the aorta coming off of the heart, and it's got lots of branches, but I'm going to just draw one branch, which is the artery leading off to my arm. So this is called the brachial artery, going off to my arm. And usually, I'd say 90% of the time, maybe even more, the blood pressure that you're getting recorded, or the number that's being told to you, is being checked at this point. I marked it with a little X because that's kind of the upper arm, right? So that's usually where they're checking the blood pressure. And again, they're checking the force that the blood is putting on the vessel wall. So these little blue arrows. So that answers the where question. And certainly, you can imagine if I check blood pressure, let's say at some other spot, let's say over here or over here, you might get a different blood pressure reading than if I check at the yellow X. So really, we're just talking about that one spot. Now, the other question is, when are you checking it? So for this, let me show you a little table, or a figure rather. So imagine that over time is this way, you have different recordings for blood pressure. So this will be blood pressure. And blood pressure is usually measured in millimeters of mercury. So I'll write millimeters of mercury here. And let's go from 200 all the way down to 0. And I'll use my numbers that I got from the doctor the other day to illustrate what I'm trying to say. So right at that X, that yellow X, at the bottom, let's say, of my reading, I've got 75. So let's start at 75, which is about here. As the heart is pumping, the pressure starts building up, and it gets up to about 115. So really what is happening is blood is making its way from the heart as it squeezes towards that X. And as it gets there, the force that it's putting on the walls is going up, up, up. And as it goes up, it goes from 75 all the way to 115. So that all happens during the squeezing part of the heart cycle. And we call that systole. So this is all happening during systole, which is when the heart is squeezing down, and we know the heart is a pump. Now, from that point forward, the heart begins to relax. So at this point, at 115, the heart is now relaxing slowly. And as it relaxes, the pressure begins to fall. And it continues to fall all the way up here. And the pressure gets down to about 75 again. And this is diastole. So this is when the heart is actually taking a break from squeezing and is now refilling, and we call that diastole. So I'll call that refilling. And so during systole, you spend about a third of the time. And in diastole, you spend about 2/3 of the time. And I'm talking about one heartbeat here. So this would be one heartbeat. So it's not 50-50. And the easy way to remember this is in a given day, 24-hour day, I spend about 8 hours working and about 16 hours relaxing or not working. And so I think of the heart doing its squeezing, its work, for 8 out of 24 would be about a third. Kind of the same as me. About a third of the time the heart is relaxing, or squeezing. So that's how the heart is spending its time, in systole and diastole, and the pressure is ranging between 115 and 75. So really, it's never just 115 or just 75, it's somewhere between the two. And, for example, if I checked right here in time, it might be, let's say, 85, or here it might be 102, or here it might be, let's say 87. So it's somewhere between 115 and 75. So this number then, this number I wrote up here, becomes a range. This is the range of blood pressure. So when I talk about when, it really depends on when in the cycle you're at, and you're somewhere in that range. And when I talk about the where, we know that we're talking about a reading that's taken in the upper arm. So those are the two thoughts that should cross your mind every time you hear a blood pressure recording. And of course, the top number, 115, again, is the systolic blood pressure, and 75 is the diastolic blood pressure.
So that's a right in there, that's a lot of important information that we will build on as we go through. The thing with it is remember that it's arranged. If you had an electronic blood pressure cuff on your arm and you took it, then you got 115/75. You waited 3 minutes and you took it again. It may be, like Con was saying, it may be on one side or the other. It still sort of fit in that range between sort of 115 and 75, but there would be a range. So you would start trending those blood pressures, looking at the range of blood pressure. So when we do this, we get a series of blood pressures. We compare the series, just like he said, because it falls within that range. So if you have one that's 115/75 and you have one that's 200/110 on the same person, then that one blood pressure is probably not correct, right? It's too high. Blood pressure just doesn't shoot up like that. So you have to go back and recheck the blood pressure because it just wouldn't be correct unless the patient's condition has changed. Then it could be correct. But those are the things that we will build on later. When we look at the guidelines, the systolic pressure for an adult, 140 borderlines on hypertension. Hypertension is abbreviated HTN. When we look at it, HTN, capital letters, hypertension. Systolic-wise below 80 is bordering on hypotension, low blood pressure. It takes a systolic pressure of 80 to perfuse the kidneys. So if you fall below 80, you're not getting enough blood flow for the kidneys to work. So the patient could go into renal failure. And the diastolic above 90 is borderlining on hypertension. So if you have a blood pressure that is consistent, 140/90, in that range somewhere, then they're borderline hypertensive. So that patient would go to the doctor, probably get put on blood pressure medicine until they can get their blood pressure under control. Or look at other things that could be causing the high blood pressure. The same way in pediatrics, 6 to 14, and you guys don't fall in here quite yet. Y'all would fall more you would be into the adult range, except that you're really young and some of you are really small. So your pressures are going to be somewhat different. It would be like your pressure probably is right around the systolic 100, which is going to be sort of difficult to hear. So there's going to be some challenges with you guys taking each other's blood pressures because they're going to be lower than the average adult. 6 to 14, the same way. You have 140, borderline hypertension, less than 80. The difference here is the diastolic. Look, something that is greater than 70 diastolic is borderline hypertension. And then we look at the younger crowd there the same way, the same sort of different numbers. No need to memorize those numbers. The number that you need to memorize is 140/90. That's borderline hypertension. That's according to the American Heart Association. These other numbers just sort of give you a guideline to know that that little baby is going to have a lower blood pressure than that adult. That little booger eater, 3-year-old, is going to have a different blood pressure than the baby. So we're not too concerned right now about the pediatric patients and the ranges of their blood pressure. That's for a different day. When we look at the equipment, you'll need a stethoscope, a blood pressure cuff. It has some long, big name with meter on the end of it. I can't say it. I've never been able to say it. Stigmagmometer or something like that. But we'll go with blood pressure cuff, okay? And it's probably something to write it down with. Make sure that you record it. So blood pressures are quite easy to take. It won't take you guys a great deal of time to pick this up. What takes time is practice on what to listen for. There's 2 different types of blood pressure. Auscultation. Auscultation means to listen. So when you auscultate a blood pressure, you're listening. When you auscultate lung sounds, you're listening to lung sounds. And we know what palpation is, right? Touch. So one you listen and the other one you touch. We're going to skip down over to palpation first, because this is the one that I want you guys to do today, perhaps. So when you palpate a blood pressure, you start out, you get your blood pressure cuff, which on the meter, when you get up and you look at it on the gauge is measured off into even numbers. When you do a manual blood pressure, it's always given in even numbers. When you look, there's it starts at 20, and then the next big bold black line is 30, and in between the two tick marks, the 5 tick marks of 2 each. So even if you can see in between those small tick marks, always give a even number on a manual blood pressure. So you take your blood pressure cuff. Who wants to? Come on up, let me. When you place the blood pressure cuff on, there's a little sign that says artery. We take it off, the blood pressure off the brachial artery, so you want to get that lined up as best as possible. Like so. You don't want it loose, so it should lower. That's a little loose, but it's okay. You don't want it too tight or too loose, but you definitely don't want, like I've got there, on the elbow. That's still too loose. Must be air in there. Okay, so it doesn't fall off, that's good. So when you do a palpated blood pressure, the thing that you're going to do, you're going to find the radial pulse, and then you're going to start with the bulb. Make sure that the bulb thing, this is closed. Righty-tighty, lefty-loosey. There's a little hole there. So y'all hear that sound there? That air sound? That means I don't have this tied off. There's no air going into the blood pressure cuff. So I need to tighten that just a little bit, just enough where the air doesn't escape out. Alright? So now I find the radial pulse. I pump up the blood pressure cuff. Until I can't feel the radial pulse anymore. Alright? Because this is like a tourniquet now. It's occluded off the radial pulse. I can't hear it anymore, feel it anymore. Then I slowly release the pressure. I think you drink too many Monsters. You drink caffeine. Okay, so her palpated pressure was 140, which is pretty high for someone your age. How old are you?
16.
That's really high for someone your age. Do you have hypertension?
So.
You drink those Monsters?
I drink caffeine.
Probably need to lay off. That's pretty significantly high for someone 16. So, her blood pressure is 140. So I would note that 140 P over P, or palpate. So what happens is I get the blood pressure cuff on there, line it up. It's not exact science, but get it lined up as best as possible. Find the radial pulse, pump it up. Can't feel the radial pulse anymore. Slowly release the air. Let it take a little technique, not very much. Slowly release the air. the needle will start to come across. It'll start to bounce a little bit. All right? Don't take the bounce. That's sort of like a yellow light. You just have to be ready. And then all of a sudden, you feel the radial pulse. As soon as you feel the radial pulse, then you note that number. And that number is 140 by palpation. So that's pretty easy, right? All right, so that's not blood pressure cuff too loose. It's all that hypertension that you have. So, yes,
Would that be the manual way?
they're both manual. Okay. So, any questions on palpation? Question?
Oh. At the beginning of the year, I remember there was one thing you told us about not doing all you do just because we could like crush an artery or something like that in the arm. What was that?
That would be this. You want to be very cautious right here because there is an artery running down through the arm right here. So you don't want to tighten this up too tight or you might hurt that artery. You might compress that artery. That's why that we always get a palpated pulse or blood pressure. So if the first blood pressure that you get, like if you guys are doing blood pressures together, the first blood pressure you get, then you would get a palpated blood pressure. Now if you do another blood pressure on the same student, then you won't need another palpated blood pressure. But if you come over and you get a palpated blood pressure on someone different, then you would need to get a palpated pressure, correct? So you always have a palpated blood pressure. Don't take hers, you get your own. Alright? That keeps us from overinflating the cuff. Because I know that she has a 140 palpated blood pressure. So now I can take that number and I know that the auscultated blood pressure is about, I need to inflate that cuff about 20 millimeters of mercury more to get an auscultated pressure. So I can pump the cuff up to 160 and I don't have to pump it up to 200, right? Which would hurt. So, and that would keep me from compressing that nerve, right? Because I have sort of a range to go by. Everybody good? Palpated pressure? Okay. So let's go back to auscultated blood pressure. Did you just take that off?
I didn't take it off. It's look.
You're killing me. So now that we have the palpated pressure, I know that I can get an auscultated pressure. I can get my auscultated pressure. Now I'm listening with the stethoscope, auscultation. So when I put these in my ears, the diaphragm, we'll go through the stethoscope in a minute, the diaphragm of the stethoscope goes over where the brachial artery is. They recommend that you don't put your thumb up in here because you have a small arteriole in your thumb and you could pick up that instead of the blood pressure. Alright? So you just use your fingers over to the side to hold this down. Now, without the, very important, because everybody does this, a lot of people do anyway, the blood pressure cuff is not pumped up. I'm not going to hear anything right here. You have to have what's called turbulent blood flow in order to hear. Alright? When I pump this cuff up, it causes that blood flow to move differently through the vessel. And that's what I'm hearing. Without the cuff pumped up, I won't hear anything. So don't sit there and go, I can't hear anything. Yeah, I know, you don't have the blood pressure cuff pumped up. So with the auscultated pressure, what you're going to do is you have the range 140, so I'm going to pump the cuff up to about 160. I'm going to pump the cuff up, slowly release the air, alright? And then, now I'm listening, so the first sound that I hear after I pump the cuff up is going to be the diastolic pressure. And you're going to hear it go, the needle's coming over, starts to bounce, then all of a sudden, boom, 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 boom. So that first sound is the systolic pressure. You will continue to hear that sound, okay? And then all of a sudden it'll go away and the needle will drop. The last sound that you hear is the diastolic pressure. On the palpated pressure, you can only get the systolic, a range of the systolic. In the auscultated pressure, you get the systolic and diastolic. Alright? So pump up the cuff, 160, needle starts to come over, starts to bounce a little bit, all of a sudden, boom, boom. That first sound, systolic pressure, I make a note of that, continues to go down. Last sound, diastolic pressure. If I miss that last sound, I'll just pump the cuff up until I can hear it again, and then let it go back down and catch that last sound. Everybody good with that procedure there? I mean, it'll take a few minutes to practice. So let's look at this gauge right quick. Here you can see the gauge starts at 20, and then it's measured in even numbers. And the first bowed line would be 30, then 40, then 60. So you look at that, and you measure the gauge off from there. It'll take some time to work with the gauge and to look at it and listening. So that's why we have plenty of time to practice. All next class, we're just going to practice vital signs, all right? In some airway stuff. So we don't have plenty of practice time when we add in, and then where you get practice as well throughout the year is, everybody gets tired of sitting where you're sitting, so we try to use the latter part of the last period to get up, because we'll have a lot of skills that you guys will do. Right? So you'll have time to practice as well. But let's look at these stethoscopes right quick. When we look at the stethoscopes, we have a variety of different stethoscopes. You have ones like this, the long blue one with the one end on it, about $3 or so. Okay? You have this one, which is probably the most common stethoscope, this Sprague with the dual head, dual tube, about $19. This is more than likely what you guys are going to buy. You can buy whatever color you wish. It just can't have any skulls or crossbones and stuff on it. Freaks the old people out when you do that. So that's 20. Or a stethoscope like mine that I've had since about 1993, it's $100 or so. I buy this stethoscope instead of that $3 stethoscope because this is the one I can hear out of. If I could hear out of the $3 stethoscope, this is the one I would have. I have friends that hear out of these fine. This is the one they use. I can't hear anything out of these. This is why I used mine. Okay? So let's go down, let's break it down and look at it. You have the earpieces, hard and soft earpieces. When you buy a stethoscope, you'll get soft earpieces in there. The earpieces, the soft earpieces are not for your comfort. The soft earpieces are for the way that your ear canals are constructed. I have small ear canals, so I have to use the hard tip. If you have larger ear canals, you can hear with the softer tip, and the stethoscope's more comfortable for you. All right? When you have the earpieces are turned outward. Not like this, but I'm just going to do it over-exaggerated. But the earpieces are pointing outward. So when you get them, you turn them outward a little bit. So when they go in the ears, they're turned outward like this. Right? As you work down, you have the tubing. This happens to be a single tube stethoscope with a very narrow diameter one, so it's not going to pick up a lot of sound. And when you buy your stethoscopes, you can cut them to length, but they should be the same length as a tie. So a tie comes down to about your belly button or your waistline. So this one's a few inches too long. I would, if this was my stethoscope, I would cut the tubing and make it shorter, like my tubing is on my stethoscope. Right? Then on the end here, you have the diaphragm end. This is the end that you would listen to right here on the brachial artery. The brachial artery is between the bicep and tricep, and it comes out on the forearm. It's right there. So that's where the diaphragm of the stethoscope would go. Sometimes you can feel a pulse there. So if you can feel a pulse there, then put the stethoscope right on top of that pulse, and it'll help you with hearing. Right? So the hearing end of the diaphragm of the stethoscope. When you have the spray, the same way with the earpieces, no different, but it's a dual tube stethoscope. 2 tubes are better than 1, so you're going to be able to hear more. However, the way this one's constructed, you will get the vibration of this tube here. So that's a drawback. But the 2 tubes are much better than the 1 if it's not the narrow tube, but if it has a wider single tube, it's better than the 1. So now you have the diaphragm, same diaphragm, but this is a dual head stethoscope. So you flip it around back and forth. The smaller head is used for pediatrics or heart tones, so you won't really use it. You will use mainly the larger diaphragm on here. This is a very good stethoscope. These are very good teaching stethoscopes. There's nothing wrong with them. These are probably the most popular that they have. Mine is called a Littman, brand name, and it's a very good stethoscope. All right. But they're expensive. You guys don't need a $100 stethoscope. Now, if your parents have, like I had one student, her mom let her borrow her cardiology, the same one I have. That's fine, but don't lose it. I'm not responsible for it. Neither is the hospital. So if you borrow a stethoscope from your parents, make sure that you keep track of it. This one has a little white one earpiece because I lost one, fell off, and these are $10 a piece or a pair. So I just found a little white one to put on there. It's a dual tube stethoscope, but the 2 tubes are inside together. They're what would you call that? They're sort of bonded together. So it's the diameter of this single tube is the same as a 2 tube stethoscope. So you can hear quite well out of it. It's very sensitive. It has a dual head on it. I have a pediatric insertion for mine. This little rubber thing is to listen for pediatric patients. And they last a long time if you take care of them. You buy your stethoscope, don't hang it from, you see a lot of people throw them up on their rearview mirrors and the back of their cars. The heat will dry out the tubing. So to keep it out of the sun, or it'll dry up and crack. And you can see this one's sort of my size. It goes down to like a tie. The problem with the shorter tubing is you have to get closer to the patient, but you hear better. The other thing that you do, when you put the stethoscope in your ears, you see me moving my head back and forth. That's helping me seat the earpieces in my ears. So I get them there and I move my head back and forth to seat these in my ears. Okay. The other thing that you can do, it may look a little strange, but you can leave your mouth open as you take the blood pressure. That opens up the eustachian tubes and allows you to hear a little bit better. So any sort of thing to help you hear somewhat better is good, right? Any questions on the stethoscopes? Say again? You can get them at the scrub store, Walmart.